Okay. Well, we do try to start on time. Again, we thought and we probably will have others join. In many cases with these things, people just kind of presume that we start 5 or 7 minutes late. Well, that's okay. That's okay, but we don't. We start on time and we get going because we got a lot of stuff to cover. I'll speak specifically with you because you're here. You haven't been to one of these before, have you? I don't recognize. I don't think.
Um, I don't think so. Not a workshop one. I've
Okay,
been to a number of different presentations.
sure, sure. Okay, well, cool. Maybe and maybe it'll end up being familiar with you. But this is Interop Workshop with Ron Wilson, and it's a community service that we do for the healthcare IT community overall. Because we've got some pretty big brains here. I'm trying not to give Ron the big head in saying that. And we do this kind of stuff all the time. We find with our clients and other associates that we do, there's lots of times that people just simply don't know of the things that can get them. And so we decided to put the Interop workshop together to have it be like this, an interactive session where we can talk back and forth. We'll be glad to present the things that we want to, but we really want to encourage everybody, yourself included there. Obviously, it's interactive. So if you need to raise a hand and say, "Hey, wait a minute, explain that to me a little bit more," we're happy to do that. It's interactive. Please do so. We're getting more and more that are coming in right now on this. Thank you for showing up. We do like to have microphones on and cameras on. So, because I will call on you, and I'll call on you absolutely if you don't have your camera on. That's just how it works around here. So protect yourself at all times. Lots of times we end up, we look in somebody's ear because they're busy doing other things that are on there. That's okay. Turn your camera on and make it interactive. By the way, you'll never know that you might, this is not a big world that we're playing in here. So it's not surprising that if you're here, you probably got somebody else that's on here that has the same kind of problems that you do, and you might find somebody that you're really that is a good business associate or turns into a good friend. So we want to encourage everybody to be interactive. There you go, Jillian. Nice to see you. If you will, I would encourage you also to open up the chat. We will put things in the chat there. I'll actually ask you for some responses, and we'll start out as you're doing things here. Hi, Justin. If you don't mind, if you want to, you're more than welcome to do some self-promotion. I say self-promotion in the chat room. But put your name out there and the company and your website if you choose to. Anything about you. Like I say, you never know when you're going to find somebody here that has the same kind of problems and/or you can work with in the future. That rising tide lifts all boats, and we encourage you to do that. As I've mentioned to everybody, this is Interop Workshop with Ron Wilson. Ron is the VP of Engineering and Product Development here at Zen, and has had his fingerprints all over pretty much everything that we've done for almost 10 years here. And he had a long history of doing this kind of work before we snatched him in working with us. So it's a really good resource for you to use and abuse, especially during this period of time. So don't be hesitant to say, "Hey, Ron, what about?" And see if you can stump the chump. We like to have a little fun with that as well. So see if you can stump him. I'll sweeten the pot a little bit if somebody can really stump him real good. So try it. It's a good thing. As I've mentioned, everybody's got cameras on, and don't hesitate to go off mute and pipe in, and away we go. Okay, that being said, that's 5 minutes too much listening to me, but I do want to give a couple of moments here, give you a little history of where we are, because it's part of the agenda for today's discussion. This is actually our 11th Interop workshop that we have done. As I mentioned, it's a community service because we found that a lot of folks get surprised or otherwise hit with issues in trying to do data interoperability simply because they were unaware, and because we do it all the time and we're experienced with it all the time. Hopefully we can give you some heads up on be aware of, or here's how to do that best, and we're happy to do that. We looked at what we did out of the first 10 episodes of Interop Workshop from last year. And we were really kind of surprised as we were doing that. We covered a lot of territory, and I wanted to just, for those of you who hadn't been on one before or hadn't seen what we're doing, I want to give you the 411 here of what we covered. And when I get to the end of this, if you'd like to get the recordings of it or a synopsis of that or anything like that, just put something like, send me the list in the chat, and we'll make sure that we go through that after the end here and send you those links so that you can get that kind of information. The biggest one that we did in overall interoperability last year was a DIY interoperability, and the subtitle to it was "Great Until It's Not, and What to Look Out For." And we thought that was going to be 1 hour. We'd cover a lot of topics. That turned into three full sessions, covering things such as everything from the criticality of what you're trying to do there. How mission critical is it, from security to maintenance, scaling it, the complexity, disaster recovery, the maintenance and the costs of maintenance, and when to start looking at, is this really still a DIY kind of thing? And I think that they're, coming out of that in the comments that we got, it was really quite clear that, while we support the DIY, we'll help you do DIY. In many cases in today, you start a pile, and that technical debt comes up sometimes pretty fast. And we want to help encourage you to make good decisions with regard to how to do that and be part of the solution here overall. We also had, just from an overall standpoint, the current versions of how to connect properly, and the older, which still very much works and still very much is in use, of VPNs aren't necessarily the best way to do that and scale going forward. So we had a lot on that, and then we talked about the complexity, really specifically for the IHE profile kind of stuff in the national networks. Huge topics in 2024. Complexity of the IHE, sync versus async transactions, directory management, which we'll cover more here today, smart selectivity and use of things like geofencing and how to really take advantage of those, the onboarding and testing for the national networks. A big one, which we will cover more in just a moment, was TEFCA and what Epic's announcement did and is still going on, and will be going on through 2025 with regard to that. We'll cover, as I mentioned, we'll cover that more in just a couple of minutes. And the TEFCA and the definition of treatment. So those are the areas that we covered last year. Again, if any of those, or though you'd like to have the list, a more detailed list of those things that we covered, by all means, just throw something in the Slack, and we'll make sure that we get that stuff to you. All that being said, I know it's a lot of background and a lot of homework there, but I think it's kind of important to set the tone going forward. And we are going to be doing this every month here going forward. And we want to encourage you to not only participate in it, listen to it, because we will cover a lot of topics that are worthwhile, but challenge us with your problems. This is an opportunity to pick on Ron or anybody else that's in Zen. If you got questions, or you want to know how to throw questions and say, hey, put this on a topic, I want to hear what you guys have to say about this kind of thing. Throw it in the chat there, and we'll figure out how to add that to a future version there as well. And if we have time at the end, we'll open the forum to, again, like I said, stump the chump and let you throw something at Ron. Okay. The migration, the biggest one that we chose, topic that we chose to put on the list for today is the migration that Epic is doing from Carequality to the QHINs. And just as a little bit of background, if you're unaware of it, in approximately September, to Epic, and we really tip our hat to them in doing so, announced formally to the world that they are going to TEFCA, and by the end of 25, all of their sites will be on TEFCA and on out of their QHIN. That's great that they made that announcement and are not surprising people by that, but there are also a lot of questions with regard to, okay, I'm getting to it now, or I want to get to that 900-pound gorilla now. How do I make sure that I don't lose that connectivity at some point as a surprise during 25? A big issue. I'm going to throw it over to Ron, but I do want to make sure that I'm being very clear with you. Epic has not said that they are turning off anything formally today. So I don't want to misrepresent that and put words in their mouth. But if you read between the lines, their migration almost assuredly at some point will impact the existing connections and how you get there. So I want to make sure that we don't not misrepresenting what Epic is doing from that standpoint. With that caveat being thrown out there, Ron, we've got a lot of details that you've been working on in terms of what the effects of those are. I'll shut up and let you run with that.
Welcome, Rakesh. Good to see you there, buddy.
Hey, nice.
So, the whole idea here of Epic and TEFCA and CEQ can be a little scary, right? And daunting. And that's the reason I think Jim was making some clarifications there. We definitely don't want to be putting words in Epic's mouth or implying action at Epic. All we're doing is observing and trying to convey some of those observations to kind of read the tea leaves, as they say, right? On what do you do next? Some people we've talked to would say, I don't need to worry about this till next year because not everyone's going to be migrated until then. Well, unfortunately, I don't see that's how it's going to happen. And you got to keep in mind there's multiple tiers here. There's a bunch of business stuff, but when we really think about the technical aspect of it, you've got a healthcare system who has facilities that are going to make decisions and they're going to drive those into their discussions with Epic. And that's really who owns this decision to go from Carequality to TEFCA and when, and whether or not they'll continue to participate in Carequality. So it's not really Epic's decision. It's the individual health systems and or facilities relative to their engagement from a business perspective in the networks. And so what we're seeing today, TEFCA's live, it's active, and there are currently 15,000 facilities registered in the TEFCA directory to exchange data under the TEFCA framework. So in comparison, in Carequality, we have 118,000 facilities. These are individual components, entities of a healthcare system. Think of a large healthcare system, all of their outpatient entities, their off-site ERs, all of it, right? Whatever entities exist in their ecosystem of Trinity Healthcare or Common Spirit or Baptist Health. And then an eHealth exchange, which is a QHIN, they have 35,000 facilities that are registered there. In an eHealth exchange, it's different types of entities that we're typically seeing than Carequality or even TEFCA. You got a lot of the HIEs in that space. You've got some other data sharers that are really unique in many ways, data aggregators and other things. And when we look at the current TEFCA directory, I've started to want to see the crossovers, right? Net new, who's in both, so if you're an eHex participant only, who can you get to in that TEFCA directory? If you're a Carequality participant only, who can you get to? And then what's going on exclusively in the TEFCA directory? So what we're seeing is that about 6,000 entities in the TEFCA directory today participate in eHealth Exchange. So about a third of those TEFCA entities you can get access through eHealth Exchange, not TEFCA, eHealth Exchange, standard eHealth Exchange, DIRSA agreement. So in the Carequality space, it's about 14,000, right? And again, a lot of these numbers are individual Epic facilities. When we look at TEFCA only, we've got about 1,000 facilities that are in TEFCA only today. Now, they just made this announcement in September. We just had the national meeting in December, and we've just gotten a organizational management committee for TEFCA rather than it being kind of the aggregate care team, right? So there's been movement in the TEFCA space. We've got solidified SOPs that didn't exist in September. We've got movement in SOPs, committees acting on SOPs, and we got 1,000 facilities that are only in TEFCA today. Jim and I were talking about this morning. What does that mean? I said, I'm not sure what it means. And I don't know exactly what it means. All I know is there's a number, 1,000 facilities that aren't in either network for that OID. And I think as I thought about it, as I was pulling these numbers together, it really is a multitude of things. It's potentially folks that never participated in Carequality for one reason or another, and now are signing up for TEFCA because there's a use case they want to use, they want to leverage with a responder or initiating, whatever that is. There may be some that decided they don't want to share data on Carequality anymore and said, I want to move over to TEFCA right away. That's their prerogative as a facility, right? Again, I want to reiterate, that's not Epic's decision. That's the individual health system facility's decision. But what we're seeing in just this first month of activity, we're getting a disparity of accessible data for Epic systems on TEFCA, and we don't know what that velocity is yet. I don't, next month, if I do this again, if that's 5,000, now we got a hockey stick shape that we got to start to react to, which is really where we're kind of going with this discussion today, right? We've talked to a lot of our clients. Meryl Lee and I just did 3 shows from September till January, and we're getting ready to do 2 more. And we're talking to people in the health tech space all over the place, and this is a discussion. TEFCA, what are we doing? How are you doing it? Zen is QHIN agnostic. We are going to be an on-ramp for folks to go to eHex or Commonwealth. Right now, we're working on our Commonwealth service adopter. My guys are about 1 test case away from submitting that, literally right now, which is exciting stuff. And it's something that I think in December, it was a wait and watch. And I'm kind of getting to the point where I don't know if it's a wait and watch for very much longer, right? I think it's a situation where you've got to come up with a disposition and a plan and start to execute it sooner than October, right? From a road mapping perspective. Or you may get left without access to data that you're, actively getting access to today.
And I think, Ron, that's that's the crux of the whole discussion. For most people that are here, you're not with Epic, or you're not with one of the major EMRs that is building their strategy, and they're taking that for you. It's most of the people that are on this call and/or would be listening to this have to be thinking about the strategy of how do we get that information and how do we maintain getting that information going forward, and not get a surprise cutoff or something that you weren't expected, because this is healthcare IT. Nothing goes, oh, well, let me just fix that. It just doesn't work that way. It takes more to it. So we just want to implore you, whether you're doing it yourself, whether you're dealing with one of our competitors, whether you're one of Zen's clients and doing it, the importance of you having and building a strategy of how you get from the beginning of 24 with something that works, or what your strategy is, to where you sail through 25 without, okay, we knew that was coming. it's not a problem. We've already got that nailed, and we don't have a disruption, because disruptions nobody likes at all. So we encourage you to have a strategy with regard to that. I'll pause there. We covered a lot of territory. We've got a few more new people. For those of you who are new that just came in, I encourage you, turn your camera on, put your microphone, open your microphone up. That's how we do this. This is an interactive session, so don't be bashful here. You never know when you're going to meet somebody that can really help you going forward. With that being the case, I'll pause. Any thoughts observing? Jim put something in the Slack there. Maybe they aren't entirely certain what's the best sign up path may be. Yeah, Ron, thoughts?
Yeah,
on that?
that's really, Mary Lee on our side. Mary Lee's the business, guru relative to these networks. She knows the rules, the regs, the contracts, and the mechanics. There are reasons to pick, as an example, a particular QHIN, and most of them are business reasons or use case reasons, but those are yours, which is really why Zen's going to be QHIN agnostic. It's one of these things where you may want to take advantage of data in the Commonwealth network, or eHex pops up with some feature or function that you want to go, I need to leverage that, right? And that's why you're going to do that. The beauty of it is once we get to the TEFCA network, we can get to the rest of the participants, right? So it's a network of networks, and everyone needs to kind of conceptually grasp that, versus kind of what we've had in the past. eHex became a Carequality implementer a year ago. Prior to that, you had to do both networks or you were missing data sources, right? And so eHex introduced the concept that they were going to be a Carequality implementer, and you could bridge to Carequality through eHex. TEFCA is that whole idea on steroids, right? All of these QHINs are going to be interconnected. They're going to be transferring between each other, and you're going to be leveraging the services and constructs of your QHIN that you've joined. So that decision on where or how to sign up is really a discussion. You should talk to somebody like Mary Lee, get some guidance for your use case, what you're trying to do, and then make that decision to sign on to a particular QHIN or another, right? 3 or 4 of the QHINs are going to be EMR technology platform based, right? Like I don't see anyone becoming part of the Epic QHIN if you're not on the Epic system. I don't think they're going to offer services to technology folks. They may at some point, but right now I haven't heard anyone talking about that. They're just a QHIN to manage their client data access in implementation to the network. And I believe, was it Allscripts is going to be one, and ECW is working on theirs with SureScripts, I believe. So, we're going to see evolution there in that regard. But, to kind of go through why you want to participate in TEFCA use cases, SOPs for data access. There's changes in the treatment space, which is partially what drove this, but there's also changes to opening up other use cases, right? Individual access or patient-based data exchange, meaning a patient can get a hold of their own data and they can control that data and do with it what they will. We're going to have operations or operations support types queries. Folks are going to start supporting that. So your billing transactions, claims, these kinds of things. Authorizations are going to be use cases that are going to be, injected here too. So there's going to be a lot of reasons to make that decision, honestly, and they're not going to necessarily be technical. They may be technical a little bit from a use case, but many of the times they're going to be driven from the top down from a business case. And I have to be careful because I always kind of dip my toe in that business side because it matters a little bit. And then Mary Lee dips her toe over the technical side, and we kind of have to help each other on both ways, because it does play into the discussion.
Absolutely, it does. There's a big gray area between it, and in some of our the discussions that we had in 24, we touched on that quite a bit. If you're steeped in the technical aspects of this thing, you really can't, like Ron's talking about, you can't just simply go, okay, well, that's a business thing. I don't care about it, because they're interrelated. So I will take that opportunity to be a shameless plug for Marilee's office hours as well. We do that monthly. That's from the business viewpoint, and much more the legal and what are the requirements kind of standpoint. She does have that. If you want to get information on when she has that, again, open mic, open discussion kind of chat, go ask an expert kind of thing. She does that regularly. I believe the next one is coming up on the 27th. They're at 11:30 Central. If you want the invite to that, just throw something in the chat and say, yeah, at least you have the opportunity to get some additional information from that. And, again, I won't give Ron the big head. Close your ears, Ron. Between Marilee and Ron, you probably can't find a better source of information on these things. It's why we do them. It's important for everybody to be aware. So make a note of that and make that a resource for you. So as we go forward, Ron mentioned a couple of things here, and of all the things that we talked about, in addition to the Epic thing that we tried to select for this going forward, was, we picked the topic trust and how it impacts the technology and support for delegation of authority. We selected the directory management, which you would think it would be simple. It's not. And the individual access IAS, as Ron mentioned there. So we're going to go through those three. There are more we have on the schedule. Depends on how much time we have for that. But let's start with the trust and how that plays into the technology and the delegation of authority. TEFCA's definition of treatment is very different than it was before. Ron, I'm gonna throw this to you. Start there, and
Yeah.
How does this affect things?
So under the original national networks, treatment was defined very loosely against the definition of HIPAA, right? So it's pretty broad when you read it on who would be providing treatment to a particular patient. Under TEFCA, it's aligned explicitly to a covered entity. And the way that they've worded that now, it really took some elements that were getting managed as treatment in Carequality or eHex and excludes them. They're more operations requests, right? They're not actually treatment. And everyone probably knows about the hubbubaloo this summer with our buddies at Particle and Epic, but they were using Particle's defense to some degree. We're not picking sides here. It was so broad that you could say, no, we're providing treatment. That's our interpretation, and that's why we're querying. Oh, you don't like it? I don't, pound sand. I don't care. Well, TEFCA said you can't say pound sand anymore. Here's the rule, and it's very explicit. Okay, but they also folks can opt in to that broader rule under TEFCA also, because there's big treatment, which is what the original HEPA rule is. And then there's TRMNT under TEFCA, which is the new, very explicit treatment use case. So there's good things there, because what we got out of that as network data consumers is we got a commitment from ATSP to enforce support for other query use cases. So as an example, a patient use case was supported under Carequality, but the compliance rate was about 0.1%. Okay, so it was really de facto dead on arrival, right? Frankly, under TEFCA, if you participate in TEFCA on 1/1/2025, you have to support IAS use case. You have to support a patient query. End of this year, we're going to get 3 new must supports, but can charge for. They can't charge for IAS, but they must support 3 new use cases. I won't get into them today, but they can charge for them. And these mirror use cases that are actively going on from the Social Security Administration, the VA DoD for benefit determination. Okay. Social Security Administration today is paying responders for a patient record to do benefit determination, disability benefits, and so on. And so we're probably going to see a very similar pattern in TEFCA. Now, these are going to be operational use case, healthcare operations, payment management, these kinds of things. But as a consumer of data, you can reach out. You can say, what do I got to pay you? They can say, I want 250 a request. You can say, I'll pay it. I won't pay it. Welcome to capitalism, right? It's not for treating the patient in an emergency room. The messaging structure from a technical perspective under TEFCA is changing. Not dramatically. We're still using IHE. We're still using SOAP-based. There is FHIR going on for some of the billing in the other edge cases, but they've expanded the IHE specifications and the way we're building the messages to support some rules around trust. TEFCA's whole underlying construct is a trust framework that folks can make sure that the data that they're sharing and that they're receiving is at a certain level of expectation in a certain known state. And it's important. If you've gone to HIMSS or you've gone to health conference, we have a much larger young health tech entity space than we've ever had. When I went to health in Vegas, the young health tech entity space was as large as the existing health tech space. At HIMSS, that was never the case. It was a little corner. It was a little corner. There were 50 guys over there in a row that were startups trying to get money. At health, 9 months later, at health, it was a giant space of companies doing lots of things, cool stuff. Those guys don't understand the space. And that's why we're seeing this movement. We want to engage those folks, but they need to be in the scope of the trust framework, right? And they need to understand those rules. That's why we're seeing this movement. With that, we're seeing changes relative to managing the hierarchical relationship between parents, children, and grandchildren. I mentioned these hospital systems, right? These hospital systems, they have almost all of the large ones have every EMR in the ecosystem in their space. They'll have their ambulatory clinics on Allscripts. They may have them on ECW because they bought out a practice. They may have some on NextGen, and they're not migrating all those holistically at once. So what we'll see is a broad level of registered entries under Trinity Healthcare, but it's 5 technical solutions. Couple independent individual instances of Epic, a bunch of ECW stuff, a bunch of Allscripts stuff. And we're seeing movement in how to manage, how does this child or grandchild connect up the chain to that healthcare system, and how does that relate to trust, right? Again, trust is the underlying, key thing.
So I'll ask the question. So Ron, why does that matter when you're talking about directory and from a technical standpoint? Wink, wink, nod, nod.
Yeah, one of the big issues that we've been battling, again because of our battle with our friends here this last summer, was you put a new entry in the directory. Who are these guys? What do they do? And so I would get personal emails, phone calls from Epic team. We'd add a new participant around. Who are these guys? What do they do? What, why? Blah, blah, blah. Oh, okay, guys, this is who they are. This is what they do. Send them an email, give them the details. They'd go vet them. And we were all chasing our tail through this process. My client, who is what we call a candidate implementer, meaning they have these children clients for their tech product, and then Epic and our team, because I'm herding the cats with my client's herding his client, and Epic's herding me, so we're all doing this thing. So under TEFCA, we went to the R4 directory. Well, under the R4 directory, we now have this thing called delegation of authority. It's a whole new element in the directory entry that can register what they do. And at the national meeting, we had some breakout sessions, which was really kind of fun. And, being in the trenches here, and talking to higher level, high thought people, it's like, why don't we get all of this granularity of these details that folks want relative to trust, and let's get it into the directory entry so they don't have to call me. And I can cover it up front, right? I can go to my client and say, here's a form, fill the form out, give me the form data, I'll get it in the entry, and then whoever consumes the entry can go do it. So we're doing that, but we're not doing it that way. So we're getting there from a compliance and in a conformance position, but we're going to start seeing upfront vetting before I can even add you to the directory. And there's going to be some forms and some other things that will have to get filled out. And basically, they're trying to, from the business side, address the use case, confirm big treatment and trust, and eliminate everybody having to go do this herd the cat problem behind the scenes, right? Which is what was going on.
Yep. And to be very clear with everybody, okay, it's a pain to do that over and over again, as you heard from Ron, but it is very valid for them to be asking those questions. I mean, we all need to play by the rules, and what we're trying to do here is make sure that we are capturing the correct information and being able to provide that automatically so that we don't have the overhead associated with all those phone calls and emails that who are these folks and what are they, and vetting them again after all the other work is done. That certainly affected us, but it also affected our clients, and we're not the only ones. So whether you are whether you are representing a surgery center where it's pretty obvious that it is treatment, you're probably not going to get that many questions about it. But all of these other new things, all of the more health tech, that it isn't obvious whether it is treatment or not. If you don't know those kind of questions are coming, you should, because that's what we're trying to do here is give people the heads up. Some of this stuff we're going to have to all jump through some hoops to make life a whole lot easier for us all as we go forward. And, this is not a 2 or 3 or 4. There are a lot of entries in that directory.
Yeah.
And there'll be a whole lot more. Go for it, Ron.
118,000, and eHealth didn't even support the concept of delegate of authority, or OBO, until late last year. And OBO, delegation of authority under TEFCA, that's what we're going to call it. We're not going to call it on behalf of. In Carequality, we call it on behalf of. This is where a condition where an entity can have, health tech vendor that's going to do patient engagement management, right? They got a software solution. They're texting patients. They're making sure patients are getting their, treatment kits, getting prepped for a procedure, whatever the case may be. It's under the treatment use case, so that entity can query the network and get lab results and other things. But that entity doesn't generate clinical data that needs to be responded to the network with. So an on behalf of, or a delegation of authority, would say, I want to engage ABC company here that's going to do patient engagement for my gastro practice, and I'm on ECW. And so what you can do is say, for Dr. Bob's Gastro, I'm going to query on behalf of him, newfangled patient engagement solution, but over here, ECW is the responding gateway for them. Okay, so you're basically saying, I'm going to query on behalf of Dr. Bob, and if you want data from Dr. Bob, I don't have it, ECW does over here, or Athena does, or whoever, right? That's delegation of authority, and under TEFCA, OBO under Carequality. And we are starting to see this explosion of innovation and technology implementing these use cases, right? Because, yeah, maybe ECW has a patient engagement component, but it's not a company that is just zeroed in on patient engagement, that's got the magic voodoo, as I call it, right? And maybe that practice is saying, ECW, I like the rest of it, but the patient engagement side's not quite what I want. So I'm going to go over here to these guys. They've got what I want. And so that's what we're seeing are these specialty things. AI, of course, in all kinds of uses are coming into play with companies doing this for folks. So we're going to see a lot of that happening. And that's what's really they're setting the stage for. How do we get this explosion of innovation in place and manage that trust position, right? So that we can implement the tech.
It's a beautiful segue into another topic that is volume of transactions and responses to those transactions. So we're going to come back to that in just a second. We're going to talk about individual access because that dovetails directly into it. But we've covered a lot of territory here, and it's easy. People get bashful or they're doing other things. I'll pause. Any hands in the air? Questions, thoughts, observations based on what we're or anything else for that matter? Ron, you must be really good at explaining this stuff. I'm telling you.
You're killing me, brother. You charge them all with Chump and the Stump, and then you scare them, and then you cut me loose, and now you're going to put me up. I don't know.
Yep. Boy, I tell you, put a quarter in him, and he just goes for all night long. Let's talk the individual access services, and then we're going to come back to the onslaught of inbound traffic. So, just for everybody's level set, what is the IAS, individual access service, TEFCA, and what are the timeframes for what's going to happen?
So what we're seeing is that, folks are starting to understand that they can't fit into the treatment use case. And the answer to that is to leverage the individual access or the patient access, right? The patient controls their own data, which is ultimately the patient can do whatever they want to with it. So at that point, if you're an entity that needs records for some business case, whatever that is, if you develop an individual access implementation, then you are going to absolve your back office integration from the need for treatment use case. Period. End of sentence. What the patient does with that data behind their IAS request is of no concern to the provider of the data. Nobody gets a decision on that but the individual patient. So I don't want to, there are a couple of pretty drastic use cases for this concept. Many of them know they have to do with folks that we typically consider to be sharks or that none of us really like to deal with at a very straightforward level. But a patient says, "Hey, I feel like this medication hurt me, and I need you to look at this for me, Mister, slimy lawyer." And the patient can go send that data to Mister Slimy Lawyer. Well, today, Mr. Slimy Lawyer can't get access to those records because it's not treatment. Okay. Um, that's the most extreme use case I can think of. Another one is that a patient's not really ill, and I just had a discussion with a company about this more recently. People are becoming more proactive about their health, right? They're doing discovery testing, methylated testing. The Gary Brecka storyline, right? What is my prediction of longevity? Well, that's not really a treatment use case because you really don't have a condition under that necessarily unless you become a patient of Gary Brecka, and he's not doing that in mass. If you do an IAS use case, I can go collect my records, I can throw them into Gary Brecka's AI solution, and then Gary Brecka can spit me out this routine or vitamin regimen or whatever. You need to not eat these things. That's that's his main thing. There's a lot of people doing this. A lot of people doing proactive looking at these things. IAS use case gives the patient control of their own data. So today we have this 250,000 entities transacting messages. We have the DoD and the VA, the 1,900-pound gorillas querying people. Well, now we're going to add the American public.
Right.
Let's just say 200 million users or 150 million users to the mix, so it's going to be pretty astounding. It's exciting from a technical perspective. Lots of fun stuff coming.
Well, it is, and it is easy, as Ron just pointed out, that there are the potential gray areas and even the potential nefarious uses. There's also a lot of really good use cases that come out of that. So this is a technical discussion. We're not here to debate back and forth which one should or should not be there. The fact of the matter is that the IAS use case is real.
Yeah.
It is coming, and the ability, will it morph? Will it change? Will the rules? Probably. It is new, but I personally would really like to have my medical records and be able to share that directly with any provider that I want to there. And it's not them asking me questions all over again about what happened 25 years ago that I don't remember. It's there in the record, and they can actually use it. So there are some really good use cases for it. What does it do from a technical standpoint to the national networks and the QHINs? The fact of the matter is that we're all going to be dealing with more queries and the responses that are there. And we all have a responsibility, at least as far as Zen is concerned, to work carefully and smartly at minimizing the unnecessary queries. And that takes me, back to where we were talking about directory and geofencing and all those things that I mentioned that we started talking about in 2024, and being smart. If everybody presses enter over and over and over again to the entire national network to get information and just continue to query, the whole system breaks and nobody wins. If we're smart about how to do these queries and more directed and pointed at doing them, we all win, and we all use a lot less resources in doing it. So one of the things that you're going to see Zen, and we're going to be producing some more information about how we recommend and how you to be smart about those queries and how we optimize our queries for our clients in the coming months. It's a big issue to us, and we want to be prepared, and we want to protect our clients from unnecessary responses when they don't need to, or how can we optimize the system there overall. So the high availability of the systems, we've all experienced it. Man, there's certain times of the day, certain times of Monday morning, your system's getting its brains beat out. And how do we work through those situations where we use queued transactions when queued transactions can be valuable, and not hit them when we don't need them, and that leaves that bandwidth open for the times that we do. So there's a lot to unpack there, and we're going to do a whole lot more here in the coming weeks and months to optimize that stuff. So we got about 10 minutes left. I'd love to play Stump the Chump. Anybody got a good question for Ron? Don't aim it at me. I won't be able to answer it. Of course, I will try. But John, stump him. Jim, you usually have a good something.
Thanks, Jim. Yeah, I won't necessarily try and stump Ron. I'll just add my color commentary because I put in the chat about fundamental flaws, and I won't be an advertisement for what we do as a company. I've talked with Marilee about that separately. But the problem with individual access services that I've experienced with various implementation conversations is that health organizations, for fear of liability, fundamentally still don't trust that you are who you say you are and that they have the right information for you.
Correct.
So the mechanisms that they're exploring, that HL7 is getting into, that ONC has supported, God bless them, is around what I will call a pseudo IL level 2, which, to give 30 seconds of overview, IL level 2 is an identity assurance level that is a derivative of NIST security guidelines for federal systems as to how you prove your identity, get access to a system. I've been in the federal space for a long time in the past and completely understand why I have to jump through hoops to prove my identity to get access to a Department of Interior system that has, government information in it. That's entirely different than when you're holding my data on my behalf and I never asked to do it in the first place.
Right.
So individual access services, and Ron, you also painted a great picture about this, I offer is only going to increase because the necessity for people to hold their own health data as the demographics around the availability of hospitals, health systems, and specialists starts to shift downward. You're going to have to bring your data to the table in order to meet with that physician that you've waited a month in order to see. And individual access services are going to be critical to that, which means streamlining and better processing ways to create trust between organizations to know who you are and share your information. And I'll stop rambling.
Yeah, it's a great point. I went through some health issues. Many of you probably don't know this. I used to be about 450 pounds. And so I had to have a hip replaced and some other things through 2014 through 2018. And in that process of trying to get through to have my hip replaced, I have it's a data sharing problem. It really is. I had an elevated white count for a long time, so nobody wanted to touch me. They thought I had leukemia and all these other things. So I went to an oncologist for 18 months to get proofed out that I did not have a leukemia issue and it was strictly inflammation and all these other issues. The facility that I went to in Phoenix to manage my oncology treatment to get this thing vetted out to clear was bought, merged, and their EMR was deleted. So had I not had a giant folder of paper of a bunch of lab results after fighting for a year to get 275 pounds off, get through heart evaluation, to get my hip replaced in December of 2018, had I not had that pile of paper, I would have never got that authorization and that doctor to sign off on that hip replacement, right? So this IAS use case for folks that are fighting that battle or aging parents, the aging parents one is a huge thing. I mean, as they get older, they forget, and how do you keep track of it all? You're not there all the time. And these kind of products that we're going to start to see are going to give us the ability to be a support team and all those things, which is just great.
Absolutely, it truly is. And Jim, I'll ask you to give you the opportunity. Shameless plug your company. What do you do? And let everybody know how to get a hold of you. That's the community.
Oh, absolutely. I'll throw my email in the chat. Yeah, we are a startup based in Austin, Texas. So of course, talking to Marilee, we are working on a pilot project with C3HIE at the moment, and we offer a digital identity solution. Kind of like your mobile driver's license, which we're building into, so that you have your health identity in a digital wallet that you can associate with your electronic health record system or with your records themselves. So as C3HIE sends information from hospital A to hospital B, there's a verified credential with it. Both hospitals can trust that. There can be a identity verification process on the front end. But the most important thing, just like your mobile driver's license, is it's an electronic identity that has an electronic means of trustworthiness and will help streamline this process that you have to prove who you are to hospital A, send your data to hospital B, prove who you are to hospital B, and then do it all over again. And that's a big fundamental flaw, as we've talked about so far, in expanding the information sharing capabilities and portability of data in TEFCA.
Yep, totally.
Fantastic. And
Cool
it's that whole use case is hard enough when you're healthy and you understand what's going on. When you're sick and you got to do all that too, everybody knows how bad that can be. Either you've lived it or you've probably watched somebody in your family or close lived through that. It is not fun. So fantastic. Glad to support that. Glad to have you make everybody aware of the kind of things that you do. Again, we don't necessarily have a ton of people on this call, but I can tell you that a lot of people do watch this after the fact, and we're happy to have everybody plug what you do. We're all trying to, like I said earlier, we're trying to have the rising tide lift all boats, and you never know when you're actually talking to somebody that can really benefit from the services that you provide. So thank you for contributing to that. We appreciate it. All right. Anybody else got any other thoughts or that they want to take on? We've got about 5 minutes before, and we start on time. We end on time with these things. Any other thoughts?
Jim, I'll just add real quick. Olivia was on just a few minutes ago. Olivia and I are both part of a advocacy group called Connecting for Better Health, which is focused on California and their data exchange framework, which for anyone who's not aware of it, California has passed this data exchange framework requirement, which is like a mini TEFCA just for the state of California.
Yeah.
You actually have to sign up as a health entity that says, yes, I'm going to do it. I think this January or next January is the drop dead conformance date. And just like TEFCA has an entire framework of information sharing standards for different cases. And of course, individual access services are in there too. So.
Yeah.
Fantastic. Well, I will tell you all a couple of things. One is, I did mention Marilee's office hours. She's got that coming up again. Shameless plug here. February 27th, 11:30. If you want to have information with regard to that, Olivia, you just posted that information. Thank you for doing that and sharing that. Marilee's information on her the office hours is up in the chat a little bit earlier. Jessica, if you wouldn't mind, post that again so it's fresh for anybody who might want that. I do encourage you to join those. It is, sometimes you can just listen with one ear and learn something, but you never know. There's a lot of really good information, and she's a great resource. And it's free, so you can't beat the price there at all. The last thing I do want to mention here as we close out, that if you are listening to this or if you have attended this, it's not a huge group, but you're one of a few group of people that are steeped in this. I like to joke, I think I missed the joke at the beginning of this, that this is the most fun that you could possibly have and still be talking about healthcare data interchange. I stand by that statement. I'm pretty sure that it is, because it's not necessarily the most fun topic in the whole wide world, but it is a very important one. The work that you're doing and the reason why you're here is so that you can continue that work. It is awfully important. The world is changing very quickly, as I don't have to tell you. And those of us who are familiar with these things and ahead of the curve on what is coming and how to be prepared for it, there are a lot of people that lean on those that know this stuff. We want to share this. We're glad that you're participating with us, and we hope that you'll do that going forward and keep going with it. Don't lose the faith. This is important stuff that we're doing, and the people in the future will actually they won't know who to thank, but you'll know that it's you. So I appreciate you doing this kind of stuff. With that, last chance. Anybody got anything to share? Shameless plugs, bad jokes, dad jokes, anything? If not, we will let everybody go. We'll give you 2 minutes back, and do watch for your email or LinkedIn or other things. We will be promoting another one of these. We're going to get more specific in the technical aspects of this one, as you know, was pretty general in terms of what's going on in 25. We're going to get down into the weeds on some of this other stuff that is important for people to know going forward. If you have topics that you would love for us to research and be more explicit about, by all means, let us know on that. We'll be happy to include those in there. And everybody, have a great rest of your day.
Thanks for joining. Nice to see you all. Thank you. Bye-bye.
Thanks all. Bye.